Thank you, Brian, and thanks for having us. And I really want to welcome our friends, our colleagues, and our partners at the WHO, Shams, Terry, and Ed, who come soon. This is a great privilege to have this session, and it's a very important session. We work very closely with the WHO as a non-state partner and in official relations. And what we're really looking at is how can we help strengthen the work that the WHO is doing around the world, particularly now in the time of the COVID crisis and outbreak. As you know, the WHO has been leading us around the world, and we really want to know is not only how do you manage the COVID crisis, but how do you continue providing high quality universal health coverage? I think that is key, the idea of providing high quality universal coverage to people who do not have COVID, as well as providing high quality and safe care to people who do have COVID. We are hearing stories around the world of excess deaths of people who don't have COVID, and those are the ones that we really are concerned about because they might not be accessing healthcare. So in this pandemic, we have to look at it two ways. One is providing excellent care for the people who have COVID and preventing others from getting COVID, protecting our healthcare workers and their well-being, both mentally and physically, and then also providing the services for people who do not have COVID, who have chronic comorbidities. And that's also to add how to provide the preventive services that are required. So for example, how do we continue our immunization programs, our growth monitoring programs for children, our maternity programs? So these are the key issues that we need to look at. And I think you're going to hear from Shams, Terry, and Ed how the WHO views this in overall. So I'm going to hand it over to Shams. I'm just here to introduce them all and say how privileged we are at ISQua to have the team here with us today. So thank you, Shams and Terry, and over to you.
Thank you very much for that, Peter and Brian. And I'm looking forward to this webinar. Let's just get going. So one of the first things to emphasize really is the best defense against any outbreak is, of course, a strong health system. I think those colleagues that are joining will intuitively understand the importance of this. And clearly, as Peter has just mentioned, COVID-19 is revealing fragility in how fragile many of the world's health systems and services are. So this is our point of departure in our conversation today. Most of you will be keeping reasonably up to date on the latest situation, but it's important to maybe lay out some of the context. In the last 24 hours, and this is the current situation as of 1800 Geneva time yesterday, we're looking at the numbers that are placed in the slide in front of you. Unprecedented is the word that's often used, but if we look at these data, we won't certainly go through all of them, but looking at this, we can see that 70,000 new confirmed cases in the last 24 hours. And this is the situation that we're facing, and it does require focused attention from the global health community. And if we look at the global data between the 31st of December to the 6th of May, we're looking at beyond 3.5 million cases and approaching 250,000 deaths. So let's come to the substance of this webinar today. The essence is really to provide an overview of the WHO COVID-19 guidance for maintaining essential health services during an outbreak. And I'll be turning to my colleague, Terry Reynolds, to take us through that. We'll be examining the role of quality interventions in relation to the COVID-19 response. And we'll be weaving in some concepts and ideas related to disease programs in maintaining essential health services. With that, if I may, I'll hand over to my colleague, Dr. Terry Reynolds.
Thanks very much, Shams. Everyone hear me okay?
Yes, we can hear you perfectly. Thank you, Terry.
Great, thanks very much. It's a pleasure to be here with you today, though I have to say after Peter's perfect description of the situation with maintaining essential health services, I'm not sure you actually need me here. But nonetheless, I'll give you a bit more information about how we are looking at this from the WHO point of view. Shams, can you next slide? Great. There's a little bit of a lag with the slides, so we'll just do our best to keep in line with that. So this is the situation that Peter was outlining. There is an enormous stress on the health system right now. Some of that is coming from patients with COVID. Some of that is coming from displacements that happen because we are trying to channel people who might have COVID into a certain stream and people who might not have COVID in a certain stream in order to achieve safety, which is one of our key domains. Another part of the stress is coming from the fact that time, another one of our dimensions of quality, is getting disrupted as people are having access challenges, either because they have a fear of accessing healthcare or because some of the secondary effects of the transmission mitigation measures are actually making it more difficult for people to access care. So even public transport, things not related directly to the health sector, other indirect consequences of stay-at-home policies are creating a lot more time-sensitive conditions. And so there are a number of reasons people are experiencing disruptions of their preventive therapies, which is leading to more acute exacerbations. And then there's a lot of confusion going around about where and how to access care for some people. So a number of factors are contributing to this enormous stress on the health system. Then there are supply chain disruptions and displacements, two totally separate issues. One, all of the factors that I just mentioned previously are disrupting the paths that supplies and equipment need to travel to get to points of service delivery. And then there is a displacement of the volume of people with COVID and the supplies and equipment needed there, which is leaving shortages in other situations. So there are both of these factors for all of the issues that we're talking about. Healthcare workers obviously are in very difficult situations, either because staffing levels are low because of the need for shifting healthcare workers, redistributing healthcare workers for direct COVID care, or because people are in a mix of delivering care for COVID and other conditions, or because a number of health workers are themselves affected directly with COVID or having to care for family members with COVID or friends. So there are a number of ways that each of these burdens is happening. And the result is a significant disruption of health services overall and a need for national and subnational planners to really make very difficult decisions to balance the demands of responding to COVID with coordinated action to keep some essential health services up. And next slide. This is just an easy, quick way to see one aspect of what's happening. And like everything, you don't have to look at the specific numbers here, but just to say there are a number of countries who are having to postpone or likely to postpone vaccine campaigns. Now, in a kind of peacetime situation, you can say, well, that's bad, right? We want vaccine campaigns to happen. If not, we have consequences. However, the challenge of this particular situation is nothing is all good or all bad. The guidelines, every mass vaccination campaign is also a potential opportunity for COVID transmission. There's the possibility for transmission from health workers to communities and communities back to health workers. And then depending on the type of campaign, there is always, or the outreach activity, there's always the possibility that a health worker could become a vector for COVID transmission. So at the same time, as we postpone vaccination campaigns, we are creating near and medium term surges in conditions that we know will kill people. So none of these are easy decisions, and they all involve a balance of these considerations. And so as you can see, the magnitude of the disruption is very, very high and is absolutely global. Next slide. So you will see shortly in the next slide the cover of a document. It's called Operational Guidance on Maintaining Maintaining Health Services, Essential Health Services during the COVID outbreak, during an outbreak. And the goal here was to give fairly high-level guidance on how does one even approach this as a national or subnational planner. So what are the decision branch points and what are the questions that you need to answer in order to maintain essential health services during in the COVID context, at the same time that you are maintaining a robust direct response to COVID-19. So this outlines actions that can be taken. It's very concrete, but it is quite high level and does not give countries all of the information that they need to actually implement this guidance. So in the next slide, you will see the 9 areas that are addressed. And the first part of this, the document that some of you may have seen, has only 1 through 6, and then we've recently expanded it to include financing, communication, and health information systems. But as you see, all of these areas are cross-cutting, right? But the first thing is you need to have some purpose design governance mechanisms, and that means you need someone who's coordinating your essential health service decisions that is strongly embedded and linked with the response, the emergency response group. Then there's a process. There are different ways to undertake this, but countries or regions, even if it's a subnational unit, need to make decisions about what are the core essential services. In this document, WHO recommends a few key areas that should be prioritized, but this will be a decision for every country. And then there's a series of things that have to happen. You have to adapt your service delivery settings and platforms, a lot of ways to do that. You have to make sure there's some effective patient flow established, because the first part of the pathway between the moment when someone has an issue and when they know if they are a person with COVID or a person without COVID, or maybe a person with multiple things, that interval is fully shared. There is no such thing. We keep talking about COVID pathways from the very beginning onward, but nobody knows if they have COVID or not at the very beginning of the pathway. So it's important to recognize that there's an interval at the beginning of the pathway that is fully shared amongst the COVID and other than COVID pathway. Then, similar to the optimizing platforms of delivery, the health workforce capacity also has to be optimized and redistributed. And in many cases, that may mean shifts in roles that are appropriately supported and with appropriate backup and training for health workers to do this safely. And especially with regard to maintaining the quality performance of services, because it isn't simply the case that we need to be calling in backup without appropriate support, because introducing services without a quality consideration is likely to be not only ineffective, but potentially put you worse off than where you were. And then the other pillars of the other blocks, rather, of the health system, essential medicines, equipment, and supplies. Then 7, 8, 9 are the recent extensions that I mentioned, and those are really cross-cutting from the areas above. Each of the ones above have financial considerations, communication considerations, and health information considerations, but there are cross-cutting elements to the infrastructure that countries can approach directly. Now, as I said, though, there are concrete actions in this document, but it's relatively high level. So in the next slide, what you'll see is our plans right now. We're about halfway through this development of this. This is a detailed portal document, which will have a part 1 that will be largely the original document, plus a few additional deeper dive considerations. One, for example, we all keep saying our recommendations to countries are things like, where feasible, where appropriate, limit face-to-face provider encounters. And then we often say the phrase, leveraging digital platforms wherever possible. So we keep saying do X, leveraging digital platforms wherever possible. And yet there's a bit of a gap in how to help countries, support countries to develop the regulatory structures, the security structures, and to address the high-level considerations if the use of digital platforms in healthcare delivery is a new area for them. So that, for example, is one new expanded section. And there's a few like that. And then, most importantly, there will be a part 2 of this document where the distinct disease-specific and life course sort of stages in the life course programs identify issues that are distinct for them. So there are many, many shared considerations across disease programs and across population-based programs like maternal child health. Many, many shared considerations. And we cannot ask planners, and whether at the national or the subnational level, to address these shifts disease by disease or department by department or program by program. However, after giving a general framework as to how to do this, there really are some very specific considerations that are somewhat idiosyncratic to a given program. So, for example, I'll just give you one very simple example. Malaria, the distribution of bed nets, for example, an outreach program to distribute malaria bed nets involves very little contact, and so has a different risk-benefit analysis than, for example, an outreach program oriented to delivering a vaccine, which requires closer contact and therefore has different risk-benefit considerations. Then within vaccines, even utilizing a mass vaccination campaign that is just a scheduled campaign has quite different risk-benefit considerations than a vaccination campaign that is launched in response to a documented outbreak. So these are some kinds of program-specific campaigns that, program-specific considerations that would be different for a given program. So this document is designed to have those two parts, the general core part one that is very much along the lines of the prior document, but with some additional detail. And then the second part, which really doesn't start over and give every program's full program guidance, but really says, okay, for this particular program, why is it different? And what is distinct about this in terms of the shifts that this program has to make to be safe and deliver quality care in the COVID setting? You see here the rest of some detail on that. Next slide. Now, once we've done this, I apologize, it's a bit of a busy slide, but so once we started thinking in this way and we've offered some techniques for how to make this shift, how do you decide? So countries need triggers and thresholds for how to decide when to do what. And one of the key actions that is recommended within the original operational guidance is to, number one, identify your essential health services. And obviously that question is context dependent, right? That will depend on what is your general burden of disease in your country. It will depend on what is your COVID transmission context. It will also depend on what is your baseline capacity for service delivery, for safe and quality service delivery in your system. So once you think about those things, with those in mind, you can identify your essential health services. Then the next action that follows that is to monitor the delivery of these essential health services. So as I said before, certain health services are certainly going to be curtailed in the setting of the COVID outbreak. That is not always bad. Often that is good. You intentionally shift or modify or suspend or anticipate, even if you don't yet have transmission, you intentionally modify certain health services in order to improve quality and improve safety, and that can be a good thing. On the other hand, there are certain essential services that we know need to be continued and where it becomes very dangerous if they're disrupted, and also if people are not seeking care, even though the service is available. So in order to monitor that, these are a few proposed indicators that we're using. So this is the second part, the monitoring of your essential health services. These will obviously need to be adapted and for different contexts and for a country situation. But it allows you to think about and get a dynamic assessment of what is actually happening. So the reason that matters is the third action in this part is to identify a set of triggers and thresholds for when you would need to make changes in your behaviors. So these are a series of components across domains, and you can see, for example, just to flag one, the recommendation now is because the presence of user fees at the point of care can be a substantial barrier to care seeking, we recommend suspending user fees for essential health services. And so we are tracking, for example, which countries have successfully done that. So that's just one, that's a fairly simple indicator that can be tracked at a high level and even can be tracked over time, because some of these suspensions are for a given period of time and either need to be renewed or discontinued. Next, and then you can see anyway, there's a couple of outcome measures here as well. So yeah, sorry, go ahead, Sam. Thank you. So that is the way that we have been addressing this within WHO as an agency and within our incident management structure, which is our IMST. And the response, as some of you know, some of you may not know, we're structured into an incident management command system now, and the response has certain pillars, and this essential health services represents one of these core pillars. Now, in our broader UN umbrella, there is this framework to set out broader socioeconomic support to countries and societies. And this also has a stream, which is number one, on ensuring essential health services are available and also on protecting the overall capacity of health systems. And to be clear, in this case, it's a somewhat more general formulation. So the goal is to ensure essential health services, and in this case, protect the health system capacity to deliver services for COVID and other conditions. And then you can see this sits solidly within an enabling environment of other socioeconomic support with these other pillars. So this is just a flag to you where this context is now within the new UN framework. Next. So I'll hand back over to you, Shams, for this, and then I think we'll talk about a couple of specific quality tools as we come to them. Thank you.
Thank you so much, Terry. So just coming into this next part of this webinar, really continuing the discussion related to where quality fits in. And Terry has already outlined a number of those interface points. But let's remind ourselves that in the pre-COVID world, we recognized this figure, and I think most of the colleagues within the ISQua community will know these figures. 8.6 million deaths per year in low and middle income countries due to inadequate access to quality of care. 3.6 million are people who did not access care. 5 million are people who sought care but received poor quality care. So just repeating that, 5 million of that 8.6 million total are people who sought care but received poor quality care. And that has implications on what we do in the COVID world. And there's likely to be an increase in deaths related both to access and quality in the pandemic. We're not quite clear which will have the greatest effect. What we do recognize is that we need to address these together. So, thinking through the quality domains in any of these, we recognize that the effectiveness side, the safety side, the people-centered side, the timeliness, Terry's already mentioned, the equity dimension, the efficiency and the integration, all concepts that need to be brought to life through thinking through what the quality domains mean in terms of maintaining quality essential health services. It's also important to emphasize, and when we talk about these services, that we are talking about promotion, prevention, care and rehabilitation, all the way to palliation. And that inherent in quality health services is the need for a public health approach that considers how to optimize the performance of the entire system to achieve the best outcomes for all causes of morbidity and mortality. And all these domains really make that difference. But let's think a little bit about what that might mean in the world of the COVID pandemic. There are many, but let's just think of a few. So if we think about the effectiveness side, clearly the guidelines may not be available to account for the altered ways of working. Adaptation required. Safety, of course, incredibly important in this arena. Infection prevention and control clearly, but challenges with staffing levels to maintain patient safety. Now, people-centeredness, often mentioned, but the potential fear about using health services cannot be ignored. And of course, visitors and family not being allowed into hospitals and health facilities. Now, that's another area that warrants attention. Timeliness. Of course, this has been mentioned by Terry, increased waiting times due to staff redeployment, but then the postponement of non-essential care and what that means to morbidity and mortality for the longer term. Equity as a domain of quality, often not given as much attention as one would hope, but particularly related to COVID-19 control measures, require careful consideration. The integration piece, there's going to be clearly disruption to the usual systems, which will challenge coordination and referral mechanisms and will necessitate those difficult decisions that Terry has alluded to. And the efficiency dimension cannot be ignored here either. And when we look at any of these domains, we will need to think through the implications and we will need to think through how to plan, how to control, and how to improve. And the well-familiar Durand triangle, but the application of that is what is the most important. Now, bringing this to a person and thinking what this might mean for a person with diabetes, for example, let's consider that. Of course, an increased baseline risk from COVID-19, which necessitate clear consideration, multiple and complex health needs and interactions with services. Now you can see that the diagnosis might be affected in terms of altered health-seeking behaviour, increased waiting times. We recognise that the preventive measures that are required also will be affected. Secondary and tertiary care management of serious complications such as vascular or eye disease, clearly implicated. The medication dimensions and how to safely access medications implicated. Secondary disability, social impacts, clearly implicated. Now, all of these leads to an unhappy picture of potential for worsened health outcomes from insufficient access to quality routine care. And this requires a focus on patients, families, and communities, flexible and models of care, but also, and this is where we will turn to, the application of quality improvement approaches and interventions for the situation at hand. Let's also keep the lens on effective coverage, because while we consider all of this, we might want to keep the logic on effective coverage clearly in focus. And last week, many of you may have seen this article, but I wanted to bring this to attention, is the publication of an important article on the subject with a particular focus on health service coverage cascades for maternal, newborn, child and adolescent health and nutrition. But the principles are, of course, applicable to the wider population and well worth considering. Now, if we look at the two examples outlined here in terms of a health service coverage cascade for routine childbirth care and a health service coverage cascade for growth monitoring, promotion and treatment of malnutrition in children, each one of these, you can see, requires a consideration of the contact with health services, but will absolutely require a focus on the quality and the risk-adjusted coverage, which you see on in the examples provided. And these quality adjustments and all of the segments of this cascade will ultimately result in the positive health outcomes that we're looking for. This lens may well worth be keeping in mind as we work within the maintaining essential health services arena. Another area that requires focused attention is quality of care in fragile, conflict-affected and vulnerable settings. Many of you will remember that in one of the three seminal reports that came out in 2018 together, the Crossing the Global Quality Chasm report from the US National Academies of Science really called this out. And WHO has been working in this area, particularly focusing in on the quality of care in these settings. Now, this does require attention because the adaptation that's required and the decision-making that's required in these settings, and Terry has already alluded to some of this, will require an adaptation of interventions and an adaptation of the monitoring that's required on the delivery of quality essential health services. Turning to some quality interventions, let's think through, and this is from the WHO World Bank OECD report, and many of you will be familiar with this, but the four categories of interventions that are often considered: system environment, improvement in clinical care, reducing harm, and then patient, family, and community engagement and empowerment. Each of these blocks has interventions that require specific attention in the COVID pandemic, but maybe touching on one or two of them within the system environment. How is training and supervision of the workforce going to be adapted directly for the COVID-19 context? In terms of improvement in clinical care, clinical standards, pathways, and protocols, you can see as one of the illustrative interventions. Those clearly will need adaptation to context. The final intervention in the improvement in clinical care is the collaborative and team-based improvement cycles. It's a clear opportunity to be active in that space to ensure that quality improvement cycles are utilized effectively to deliver quality essential health services in the COVID-19 context. Reducing harm, hugely important. Safety protocols, checklists, and that requires adaptation as well. And without a doubt, the patient, family, and community engagement and empowerment requires active and intentional contribution of community members to the health of a community. Let me turn back to Terry for a few thoughts, particularly on these tools for quality improvement. Terry.
Great, thanks very much. So this is just to give you a very quick example of how we are approaching quality in the service delivery setting in one area. This is not in any way a representation of all of the work on quality, but to give you an example that happens to be particularly relevant across COVID and maintaining essential services for other conditions as well. So in the guidance that I mentioned previously, there are a few, as I said, general areas of care that WHO recommends should be a focus for efforts as countries identify essential health services towards which to direct their limited resources. One of those areas is care for time-sensitive conditions, and especially life-threatening time-sensitive conditions. So what we would generally call the area of emergency care. So I thought I would choose that one. Obviously, we also have a number of quality improvement tools for the service delivery setting in many other areas, such as, say, maternal health, child health. So this is just one of those core areas that is identified in the operational guidance. And I want to give you examples of what this means when these sort of higher level principles of quality and ensuring all of the different domains of quality kind of land in the actual chaotic service delivery setting. So one of the courses that we have, there's a course called, it's a joint WHO and ICRC course. It's called Basic Emergency Care, and these are live hyperlinks. So I believe you'll have some access to these slides and it'll take you directly to them, but they're easily searchable on the WHO website. And this is a short course to train providers of any level, but professional providers, including frontline nurses, clinical officers, mid-level providers, generalist doctors, and it addresses the syndromes with which people present, because you have to do a lot of care long before you have any idea what a person's diagnosis actually is. So it addresses how to safely and effectively and in a timely fashion respond to 4 key syndromes: difficulty breathing, altered mental status, shock, and injury. And the idea is really you can't die without going through one of those syndromes. And so this is a very practical action-reaction oriented course that helps frontline providers respond to the syndromes with which people are presenting, as opposed to other kinds of sophisticated response that providers do, but that are responding to diagnoses. So this is what you do in response to a person who is coming to you with a given syndrome of clinical need. So that is one thing that changes very much the approach, and we found in a lot of different situations, streamlines, gets care delivered earlier, more safely, people are not missing things. It's a systematic approach to each of these people. Now, this obviously has become quite important in the setting of COVID, because as I said, there's a whole interval before you know whether someone is a person with COVID or not. The difficulty in breathing module has been more significant than others with respect to the COVID cases. And this has been integrated into our COVID case management. So this is kind of a twofold a twofold tool. So it can be used you have a lot of providers right now who are either dealing more frequently with emergency cases and acute presentations than they are used to, and you have many, many providers right now around the world who have been redesignated to emergency units, a scenario, a context that is unfamiliar to them. And depending on what kind of provider they may have been previously and what environment they were working in, this action-reaction to syndromes may be entirely unfamiliar to them. It'll be very familiar to some providers. So family medicine docs, for example, are very familiar with this mode of behavior, but an inpatient subspecialist might not have done this since medical school 25 years ago. So anyway, this is one thing that can be used both on the side of COVID and the other essential health services. Then we have a number of tools. Many of you have worked in these areas, right? These are core quality improvement mechanisms. So triage, we have an interagency triage tool that is a WHO, MSF, IFRC, and ICRC joint tool, and that has been for in an extended pilot period and is now coming out formally with a manual shortly, but is available for piloting for anyone who needs it. And what that does is make sure that the resources that are available best meet people's needs and that you don't miss. So it's a safety tool that you don't miss time-sensitive conditions. The other is a genre many of you on this call are extremely familiar with, which are checklists, which are not meant to be algorithms for care, but are meant to be attention-directing mechanisms. So an individual provider or a team stops and runs through a very simple one-page set of questions, not even a full page, to say, hey, have you thought about A? Have you thought about B? Have you thought about C? And it doesn't contain all the information that you need to make a decision about A, B, or C. But what it does is focuses the team's attention for a moment on that question. And these, in many areas, these happen to be two that we have for use in emergency units for injury, serious injury, and then all other kind of medical emergencies. But these are very effective in a range of situations. The ones where they're particularly effective is where it's limited in time and space. So it is a given scenario and a given place in which it is always helpful to systematically turn your attention to a series of specific questions, which, if missed, have significant consequences. So we have these two checklists. The other is standardized clinical documentation. It may sound a bit dry. It is often looked at as your quality of documentation, but in the emergency care context, and especially in a context of surge and high volume overload in any situation, standardized clinical documentation is actually a mechanism for operationalizing a standard approach to, in this case, the acutely ill and injured. But these standardized clinical forms take young or under-supervised or under-experienced or overwhelmed providers through a series of specific areas for documentation. And what it does at the same time that it's improving the quality of documentation actually improves the rate of systematic approach to a given person and make sure that a series of key clinical questions have been asked and answered or skipped or deferred for very good reason. Make sure it's done intentionally. And then resuscitation area guidance. And this is a combination of resource guidance and process guidance that is extremely simple in terms of what needs to be where so that it is easily at hand when needed. And all of these are on our website. There's who.int/emergency care, but we can send that out. And all of those are available as concrete tools. And then there is also very familiar to a lot of people on this call, the idea of a case-based registry. And the function of a registry overall, right, is to identify cases that would be high yield for a deep dive look, for case-based review. So it's not the case that every audit filter catches a case where there was a problem, but you use standardized criteria to catch cases where it would be worth you taking another look. So if you try to do that for every case, you'll never get through them. A lot of them won't have any problems. What it does when you systematically collect information, systematic set of data points, put them in a registry, and then click a button to get the audit filters, it says, hey, because of certain criteria that are pre-programmed, here's a list of cases you should probably take a closer look at because there's a good chance that in this list of cases, there were mistakes made. Then you can identify easily corrective actions and implement those. So this is just one integrated set of tools in the emergency care area that we use as a bundle for quality improvement. We're happy to answer questions about any of those in particular, but it's on the website. Thanks very much. Back over to you, Shams.
Thanks, Terry. So that's a really good example of when you drill down to something specific that the universe sort of expands. And another area which clearly is at the height of prominence is the whole work on infection prevention and control, and particularly hand hygiene. And I think many of you will know the work related to this that's been taken forward by WHO, and particularly to highlight that there is an advocacy element to this. There is, of course, a deep technical element to this, and there's a range of WHO technical resources that can be brought to bear on the subject, all within the context of how this links with both the maintaining essential health services, but of course, clinical care for those affected with COVID-19. Now, this piece, and this is an important emphasis point, is that when we are looking at the quality lens on maintaining essential health services, there's a real importance for integrating the action on that, and whether that be on really important areas such as patient safety, whether that be for infection prevention and control, whether that be for specific population groups such as mothers and newborns, whether that be for specific disease-focused areas such as quality in the context of HIV. And of course, the list goes on. But the integration of these efforts is perhaps something that warrants specific and intentional focus. Now, the list could go on, but we can see that even thinking through the linkages here brings out many possibilities for action at the facility level, and particularly at the district level in health systems across the world. Antimicrobial resistance is an area which we will need to consider even in the height of all of this work related to quality essential health services. Let's just remember as we wrap up that the analysis from the 2014-15 Ebola outbreak in West Africa suggested the increased number of deaths caused by measles, malaria, HIV, AIDS, and tuberculosis attributed to health systems failures exceeded deaths from Ebola. If we remember that, we may be acting in a different way when we are moving forward with the response to COVID-19. Some key takeaways. Clearly, we need to keep a firm eye on maintaining essential health services while providing the quality clinical care for patients with COVID-19. We do have to have an intentional focus on the multiple domains of quality within these efforts, as we've been outlining through this webinar. We need to consider how best to apply quality interventions and quality improvement methods to essential health services within the COVID-19 context. We do need to think, and this has hopefully been highlighted prominently within this webinar, the importance of context, because clearly abstract concepts mean little unless relevant for the local realities, and that requires unpacking at the local-most level. And let's also be humble, because the destination is unknown, and we need to continue to build practical learning from frontline services and do what we often do in the quality improvement world, the do, learn, continuous process. Now, ending with this from our Director General, let's also remind ourselves that quality is not a given. It does, and these are his words in his remarks after the publication of the 3 seminal reports on quality, that it does take vision, planning, investment, compassion, meticulous execution, and rigorous monitoring from the national level to the smallest, remotest clinic. Those words ring true. They were true when they were stated, and they are true today. And particularly interesting to see how we're emphasizing the role of compassion within this work, because that is the common denominator that perhaps brings all of this together. That's us today, and I'm going to hand back to Brian. Thank you.
Excellent. Thank you so much, Shams, for a fantastic presentation. As usual, the comments here coming in are overwhelmingly positive. It was absolutely brilliant. So thank you so much. I can see Ed has just joined us now. I'm not sure, Ed, do you want to jump in for some closing remarks now before we go into our Q&A?
Yeah, sure. I would be happy to, just briefly, very briefly, listening in on this. And it's really just to offer a big thank you to ISQua. It's been a long partner for us in our work on quality and safety. And there's no point in our recent history, at least that I can think of, as someone who's worked for a long time in quality and safety of health services, where that importance has been greater. And I think the issue that we face now, in particular, as many countries are starting to consider or implement transitions out of lockdown, is the issue that we've framed the healthcare system as in two different lenses to date, and I think we need a third. The first is that it's obviously what the primary tool we have in terms of fighting this virus. The second is the consideration that we've talked about. Shams talked about it, then talking about it too, about the impact on health services and the importance of keeping those running. But the third, I think, is really as this one of the canaries in a coal mine that we need to keep track of as we come out of this transition, that unless we can ensure that healthcare workers can go back to work safely, just like every other worker in the world, but particularly healthcare workers, and then we can deliver safe patient care that responds to people's needs, that's patient-centered and high quality, we will never be able, no country, no locality will be able to get out of this spiral that we're in at the moment. So I think it's there are many different aspects to quality in healthcare, and ISQua being right at the center is a big comfort for all of us. So thanks for having us.
Brilliant. Thanks so much, Ed. Just as we transition to our Q&A period, I'm going to encourage people to get thinking about their questions now and start typing them. But also, if there are other questions in the Q&A box you'd like to see answered, you can upvote them and see them prioritized up the list. So that's something to be aware of. Before we get in, just a little bit of housekeeping on my end. Thank you so much, everyone, for joining. If you enjoyed today's presentation and found it helpful, then please check out our COVID resources page. We've collated resources from all around the world from many different contexts and backgrounds, so please feel free to check it out, and hopefully there'll be something of benefit to you. We do have a whole range of COVID webinars coming up. Another one tomorrow, The Emotional Toll of COVID-19, Consequences for Healthcare Staff and Patients, with Chris Van Hacht, Albert Wu, and Jose Joaquin Mirasolves, all leaders in the topic of second victims, and plenty more coming up next week as well. And just a quick note, one of the very small positives to come out of this whole COVID situation has been to see the strength of the ISQua community, everyone rallying together to collate the resources, to share, to help one another. So if not already, then we'd please implore you to maybe consider becoming an ISQua member or fellow, just to help us continue to support us in what we're doing at the moment, and also to broaden your knowledge in certain areas too. So, okay, yes, thank you so much again, guys. We're going to jump straight into the Q&A now. Our first question from Chitra has asked, what metrics should hospitals track as they open services in a phased approach? I'm not sure who wants to take that one now, if it's that's kind of an open question.
Chitra, thank you for that question. Can you hear me?
Yes, we can hear you, Shams. Yes.
Yeah. Okay. Now that's something that would require a very definitive approach at the local-most level. So there's, and Terry may want to add on this one, but essentially having a hospital-focused approach is important, but clearly that needs to be seen within a district and a local context. And particularly if the metrics are being directed by a national level response plan in the context of COVID, that requires attention at all of those levels: national level, subnational level, and facility level. Now, the metrics cannot be burdensome, and that's particularly important in the current context. So here, and Ed just mentioned the canary indicator approach. Here, what might be important to do is to select a select few indicators and metrics that can give some spotlight to the maintenance of essential health services and keeping a spotlight on the quality side of things as well.
Excellent, thank you,
Can I
Shams.
just add to that?
Yes, of course, Ed.
Yeah, just really, Shams, great points there. And we can share with, and Terry will be in position shortly. We've mentioned that we're coming with more detailed kind of disease area and service area by service area guidance on this. But we do have a set of metrics that WHO is using at a very high level to look at the impact on essential health services and how countries can track that as part of their national response plans. And looking at some qualitative metrics that are measuring at a national, but can, like Shams was saying, be used at also subnational levels to look at kind of a qualitative phased approach for how different service areas and how much their impact, it's severely impacted somewhat or not at all. And I think while these things may be very high level, this is going to be a situation we're living with for some time. And the fluctuations between those and the changes between those, and also, like anything, the differences within countries are way more important than the differences between countries. So being able to look across different localities and the impact is going to be really important. Many countries right now have an approach for the case numbers, and sort of red on one end of the spectrum, green on another end of the spectrum, and then some color in between to track things. I really think we should be looking at something like that for health service delivery capacity, and whether we're being able to safely and with high quality deliver on essential services as a way to flag where we've got problems. So it's something to think about, I think.
Excellent, thanks to you both.
Great, and I would just add, it's Terry really quick, I think it's an interesting question at the facility level, just to flag that it's a question that's often addressed, as Shams and Ed mentioned, at a supra facility level, so at a kind of subnational other. And there is some WHO, there's interim guidance from WHO from the 16th of April that's called Considerations in Adjusting Public Health and Social Measures in the Context of COVID-19. And there's an update on that on the way that outlines specific considerations and the main domains that you would consider in order to make that decision, to sort of assess the risk of reopening certain services or discontinuing certain public health measures. So yeah, just so there's some guidance to support that at the supra facility level. And then there's a series of assessment tools to look at your capacity to provide a broader set of essential health services. And that may or may not be, depending on context, the kind of thing you're looking for to inform decisions about those services. So we have a group of things that are sort of under the umbrella of kind of hospital capacity assessment. And that, depending on how you're thinking about this, that may or may not be an answer to the question. Over.
Excellent, thank you, Terry. Our next question from Alexander. Water, sanitation and hygiene are essential for quality services delivery and are one of the weakest points in fighting COVID-19. How are you including WASH in the personal response plans?
So if I may, I'm really glad that that's been brought up, because it's a critically important point. Certainly, we haven't been able to cover all of the different aspects of maintaining quality essential health services. But as we have highlighted persistently, the foundation of quality of care and quality of health services needs focused attention, and water, sanitation and hygiene is clearly at the core of that. It's got a lot of attention, and rightly so, and clearly this is at the local most level is a huge priority, but at the global level this is now a huge priority as well, with the United Nations really taking a focused attention on this issue. If I may also highlight that when the plans are made at national, subnational, and facility level, that needs to be embedded directly, and it needs to be embedded with the financial resources that are required for structural improvements, but also the ongoing work that's required to maintain water, sanitation, and hygiene. And WHO in the reports alongside UNICEF has clearly identified the seriously difficult and rather shocking data and information that's come out in terms of the level of health facilities that have adequate water, sanitation, and hygiene pre-COVID, and that, of course, has to be considered in the COVID world.
Excellent, thank you, Shams. Paul has asked, what mechanisms are being put in place so to have other health emergencies ongoing amidst COVID-19?
Yeah, can you repeat the question? There were other health emergencies, and what is it?
Sure. What mechanisms are being put in place so to account for other health emergencies ongoing that are amidst COVID-19?
Yeah, amidst COVID-19. Sorry. It's a great question. Actually, although it may not seem like it, or the press might not have you believe it, WHO is tracking numerous other health emergencies right now, and having just sat through today's update on the Ebola in DRC and the ongoing work there, and how they're struggling with the IPC capacity being redeployed to deal with COVID. There's also a yellow fever outbreak. There are several measles concerns. There are a whole range of other disasters. The big sort of accident in India today, the big gas leak that happened, would have been top of our list to be assisting through our country office if it weren't for COVID. So for WHO, all of these get tracked. There's a morning meeting every day at 9 a.m. where all of the quote unquote incidents are being tracked. There's an incident management team for each of these emergencies that get a grading, and it's only just happens that there's only one right now, which is it has a grading of a public health emergency of international concern. But all of those incidents are also on track, and this is why Mike Ryan, our head of the emergencies program, and all those guys look like I do right now, which is not having had any sleep all the time. But anyway, the team has been moving, and the restructuring of WHO with this new emergencies program has really allowed for a 3-level response on all of those. But we're tracking those as they come, and it's something that the integration and the work for the health systems team and the UHC team, and also our disease program team also getting involved, is, I think, helping all of the emergencies right now.
Excellent, thank you, Ed. I'm conscious of, oh, sorry, Terry, go ahead.
Just to add really quickly, we always have this confusion between emergencies with a little e and emergencies with a big E. So Ed's answer was perfect in the case that you were talking about the large scale emergencies. And then I wasn't sure of the question, but in terms of whether it's oriented to the individual health emergencies, such as, say, heart attacks, strokes, injuries, things that continue to happen during the COVID outbreak, and for which people somewhat disturbingly are seeking much less care. I think that was largely covered in the presentation, but we have sections of specific tools and specific guidance on how to maintain those services and how to decide which services to maintain in that bundle of Central Health Service guidance that we've talked about. And then one that I actually didn't mention during the presentation, I apologize, we just had come out, joint WHO, UNICEF, IFRC guidance on the community level, and so maintaining services at activities of all kinds, but health activities at the community level. So that also has a section on the health emergencies, if it was meant health emergencies with a little e. Over to you.
Great, thank you so much, Terry.